So good to be with y'all today. Really exciting. I am a blue lanyard person, which means this is my first time here at CCHF, but really excited to be here to be able to talk to you about something that is incredibly near and dear to my heart, which is finding ways to improve access to addiction medicine treatment through primary care. So I am a addiction medicine and family medicine physician and am involved with the residency program within Waco Family Medicine. And over the last 2 years, I've served as the addiction or primary care addiction medicine director at Waco Family Medicine. So the gist of this talk is essentially sharing our experience and going through our internal needs assessment and hopefully equipping you with some knowledge and strategies around how to make a similar transition of improving access to addiction medicine treatment within your primary care system or whatever context you happen to be working in. If at any point, I know that there is a Q&A session at the end, but if at any point you do have a question about something that comes up, please just let me know. And so sometimes what happens is we forget our questions. Like we have a question, we're like, oh, clarify this, and then we wait until the end and maybe we don't remember it. So if you have something that comes up organically as we go through the talk, please just raise your hand or let me know, and I'll try to answer questions as we go along and hopefully make this maybe a little bit more conversational, right? I do want to acknowledge that we have a few folks who helped with the creation and content for the talk that aren't presenting today, and I have those folks listed here on this slide. I don't have any disclosures. So by the end of today, we'll look at evidence that supports a primary care approach to addiction treatment, differentiate what sets primary care approaches apart from a specialty approach, talk about our clinical model at Waco Family Medicine and what we've done, and then ultimately be able to apply knowledge of primary care addiction medicine to some case examples. And I'll do that just at the end, telling you some of the experiences that we have, and then maybe sharing a little bit of some primary research that we're doing on the patient experience of receiving treatment in the addiction medicine space at Waco Family Medicine. So just as a reminder, nowadays I start off every talk on addiction medicine with this statistic, whatever the current statistic is. And right now the current statistic for overdose deaths from 2023 is 105,000 people died. So 105,000 deaths from a drug overdose in 2023, which is just still monumental. Now, for those who have followed this number over time, this actually is a little bit of a plateau, which we're hoping signals a potential decrease or reversal of the overdose epidemic over the next few years. So 2022, there's about 110,000 deaths. 2023, 105,000 deaths, but still a just huge number of people dying from overdose every year in the United States. So every year more people dying from a drug overdose than from the totality of the HIV and AIDS epidemics in the 80s and 90s, or during the entirety of the Vietnam War. Just really staggering number. Substance use is prevalent in our communities. So 1 in 6 people over the past year will have met a substance use criteria diagnosis. In other words, you take 6 people, 1 out of every 6 over the past year will meet criteria for substance use disorder. And this number's been fairly static over the last few years that SAMHSA has studied this. But when we look at treatment receipt, right, so take those patients who have a substance use disorder and then ask how many of these folks actually receive treatment, it's only 25%, about 1 in 4. And that number also has been fairly static over the last few years. And when you look at some of the subpopulation trends in this data, it gets even more discouraging. So when you're looking at things like adolescent treatment receipt, for example, so those in that 13 to 18 year age range who receive treatment, you may be lucky to have 1 in 10 folks receive treatment for the substance use disorder, which is super disheartening. And ultimately, one of our big motivators as to how can we innovate and improve access to effective treatments using the existing primary care infrastructure, right? When you contrast the number of people who receive treatment for substance use disorder with the number of people who saw a doctor, there's just a stark difference, right? So in 2022, 84% of people said, yep, I saw a doctor. And a vast majority of those did so through primary care. So again, this gets to this idea of we have a major public health crisis. We have 105,000 people who have died of an overdose in 2023. We have a 1 in 6 prevalence rate for substance use disorders. Only 1 in 4 of those folks receive treatment. 84% of people saw a doctor, and most of that care happened through primary care. So we can see how we're just logically setting ourselves up to really ask the question of how can primary care be able to provide meaningful and life-saving treatment for substance use disorders. And so this is the question that we've set out to ask ourselves and explore and develop a program at Waco Family Medicine to be able to do this and hopefully do this well in service of those folks in our community. So I want to briefly talk through what is different from a primary care approach from a specialty care approach, right? And so specialty addiction medicine care is a very, very big topic. And unfortunately, there are quite a few regulations and rules around what type of care people can receive in what settings. And ultimately, in primary care, our ethos is the patient walks through the door, we're able to treat them. So it's important to know where the line between these two is so that we can operate fully within the scope of our mission and live out that ethos to the fullest, right? So primary care offers that point of most contact, or offers the first contact for most people. And what research we do have looking at this issue of addiction medicine services integrated into addiction medicine, into primary care centers shows that this may reduce stigma and potentially increase retention in treatment, right? So stigma is a very, very big issue in substance use and addiction overall. And what we know is that in a specialty setting where this is very siloed, that level of stigma, either perceived or institutionalized, can be a very significant rate-limiting step for folks receiving effective care. And what we think is that in primary care, this potential is less, not non-existent, but less. Primary care clinicians, though, and here's the rub, primary care clinicians say that they're uncomfortable with screening, evaluating, and treating addiction. So there's a few reasons for this. Over the years, this hasn't been something that has been within the primary care wheelhouse, right? And so our ACGME program requirements have recently started to address this by mandating the inclusion of opioid use disorder and alcohol use disorder treatments within the residency curriculum. But historically, this has been something that has been confined to the specialty world. When we look at things like guidelines, right? So guidelines for behavioral health in general are not written for primary care clinicians, right? They're written for behavioral health specialists. And so if you look at things, for example, like the guidelines for major depressive disorder for the American Psychiatric Association or other folks, these are very much written for the psychiatrist and not for us, even though we're the ones that do a majority of this care. So ultimately, there are lots of reasons why primary care clinicians may say, hey, I don't know that I feel necessarily comfortable or proficient in being able to screen, evaluate, and treat addiction, but more often than not, the patient comes to us looking for help, right? And so there is this discrepancy between our preparedness level and the patient's willingness and want to engage in treatment in a primary care context. When we look at this idea of preparedness, right, preparedness within the primary care system, that is the ability to get patients in, evaluated, and successfully started on treatment for mental illness, and then we'll look for substance use disorder here in just a second, the U.S. falls way behind other developed countries, right? And so this is a report from the Commonwealth Fund from 2019, which said, essentially, when we're looking at the primary care system, what is the quote-unquote level of preparedness to be able to handle, again, for this slide, mental illness, and then for the next slide, substance use disorders. And the U.S. is far behind other countries when it comes to mental illness, right? So the Netherlands, 84% reported preparedness. Austria, Norway, all of these other countries report higher levels of preparedness in that primary care context, and the U.S., 46%. But when we look at substance use, everyone's doing poorly. So I guess we can take some solace in that everybody across the world in the primary care context says, yeah, this is something that we don't know that we're necessarily prepared to handle well. So, again, we're not exceptional in this case, but that's also not necessarily a good thing, right? So we may ask ourselves then, why? Why is preparedness so low? We talked a little bit about just some of that anecdotal historical narrative around primary care, not having guidelines, not having training requirements, that sort of thing. But the authors of this study that you see referenced down on the bottom wanted to dig into this question in a little bit more detail. They wanted to say, okay, we understand the historical narrative around this, but right now, given what we have in front of us, what are some of the biggest issues as to why primary care feels ill-equipped and unable to handle this wave of addiction and drug overdose? And so there were 4 key takeaways from this study. So the first was that there are structural barriers to implementing addiction medicine, right? Structural barriers here oftentimes is referred like things like policy or institutional barriers, but it also can refer to attitudinal beliefs or resource utilization within a primary care system. And so if you have a primary care system who's pulled in a lot of different directions, the ability to invest or divert some resources into developing substance use disorder treatment programming may be limited, right? Patient engagement is often a challenge. And when we say patient engagement is often a challenge, this isn't something that's exclusive to primary care. This goes back to what we were talking about as far as stigma. And so there is this idea of institutionalized stigma where the system itself, right, creates a stigmatizing environment that ultimately diverts people away from care. And so this is a cross-cutting issue in primary care and specialty care, although, as I mentioned before, we may have a signal that this is less of an issue in a primary care context, and we'll dig into that here in just a little bit and how we can leverage that primary care goodness to hopefully engage patients a little bit more meaningfully and hopefully retain them in treatment. The third point here is that there's low clinician prescribing proficiency and confidence, and this gets back to what I talked about earlier around the historical training requirements and the historical silo of addiction medicine within that specialty context. And so if you ask most primary care clinicians, they'll say this isn't something within my purview, at least if you ask them that over the last 50 to 60 years of primary care really being, family medicine in particular, being a specialty unto itself, right? And then the last thing is attitudinal beliefs. So regarding primary care's role in addiction medicine treatment. And so this is what I'll talk about, the upstream intervention here as far as what we can do to help our trainees realize that this is something that we can and should do in practice. So the rest of the talk is then going to be framed around these 4 areas. And what we'll do is look at our model at Waco Family Medicine and how we've tried to work through these 4 areas. In other words, sort of lean into this and design a system that addresses those structural barriers, design procedures that helps with that patient engagement aspect, that develops some resources to help us with our prescribing proficiency, and ultimately develop some interventions upstream for us in the GME realm to help with those attitudinal beliefs for the long term. All right, everybody doing okay so far? All right. So, first thing we're going to talk about is the structural barriers. And you'll see in the bottom right corner there's a subheading that will come up occasionally that will just sort of orient you to where we are in this process, right? So talking through those structural barriers, the engagement piece, the prescribing proficiency, and then lastly, the attitudinal beliefs. So our clinic and our system that we've developed at WFM is what we call the primary care addiction medicine model, right? So this is something I'll dig into and talk about more as far as the actual nuts and bolts of this. But the idea of the primary care addiction medicine model is very familiar, I think, to a lot of us, and that is the hub and spoke model. We realized that we had some specialized expertise in the area of addiction medicine and behavioral health that was kind of spread out in these little pockets, right? So I was working in my clinic, we had another clinician working in his clinic, and so we said, hey, you know what? Oh, and we had a nurse, behavioral health nursing lead who was working in her clinic separately. So we're like, hey, this is great. We really want to be able to integrate addiction into every aspect or every, I guess, point of contact within the clinical spectrum here. But since we have fairly limited resources, and since we have just a few individuals with this specialized knowledge, why don't we just consolidate this into this central hub and then support the spokes through that hub? And this is something that's really common. You know, Project Echo is something that utilizes this hub and spoke model where you have these experts who will bring in a population of providers all together to be able to disseminate that knowledge in a way that is just very conducive to dissemination rather than sort of having to have an expert in every single different location, right? So our structure that we've developed looks something like this. We have the hub here, which is our consultation clinic. This is where we provide clinical services for patients with substance use disorders. And this also is the home of the residency training that our residents at Waco Family Medicine receive in addiction medicine treatment. We have one of our lovely residents from Waco Family Medicine here this morning. Say hi, Blake. Everybody wave. Everybody wave at Blake. All right, good deal. And he can attest how wonderful it is. And if he's not going to attest how wonderful the training is, he can just go ahead and dismiss himself. So, just kidding. Blake will give you the residents will always give you the actual honest, like this is how it is. So, but our consultation clinic operates in this hub and spoke model. It houses our graduate medical education curriculum. And then it essentially is the source of the support for all of those different hubs. On the far right side, we have that PCP report. And so the way that we support those spokes is one, by seeing patients directly, but two, by providing review of patients. So for folks who familiar with the collaborative care model at all, there is a collaborative care model that can apply to addiction. We do this sort of informally. Patients will send us patients to review, and we'll send back recommendations as to what we would suggest for the treatment of that substance use disorder. And we also do curbside consultations. So let's say somebody has a patient that they're seeing within their clinic. They're a patient, they want to keep seeing them and keep treating them, but they need a little bit of guidance or support. We can just do that outside of the context of the consultation clinic. There is this section here in the middle, and this is something that is a service that is available both as the PCP support side of this and as the consultation clinic side of this. So we have a integrated behavioral health service that offers brief behavioral interventions for our addiction medicine patients, right? And so these are folks, these licensed clinical social worker in our clinics, but in other systems, these are folks like LPCs or even clinical psychologists who come alongside and evaluate and treat concurrently with the medical team, right? Anybody work in an integrated behavioral health system? How many of y'all do? Yeah, okay, so not unfamiliar to most people. And so this is a cross-cutting service where we have behavioral health providers in the consultation clinic, and we have behavioral health providers who are helping the PCPs in those spokes or different clinical sites to be able to offer those behavioral interventions for people. So we have this issue, and we have at least the structure of a solution as to how we maximize our resources, but we still weren't quite there yet. We wanted to be intentional about how we leverage these resources and how we can effectively utilize this model. And so we did a internal needs assessment, right? And so some of the things that we discovered that we needed along the way were nursing initiative and flexibility, and this is huge. We'll talk about nursing procedures and practices here in just a few slides, but this is really the heart and soul of the addiction medicine clinic is our behavioral health nurse. We do need clinician champions, and so this is me acting as an expert in that hub, but this is also people in the clinics around of those spokes who are willing to say, you know what, I think that this is important and I want to help and be willing to lean into this, right? We needed the behavioral health provider access to these support services, which luckily at Waco Family Medicine we already had. Talked about our integrated behavioral health model where we use licensed clinical social workers. And then lastly, we needed some tools and some resources so that ultimately we can all speak the same language, right? So if I'm doing something in the hub and the spoke doesn't understand what I'm doing, or a behavioral health provider doesn't understand what I'm doing, it can make things really difficult. And so what we decided very early on was that we needed common pathways or protocols so that we all could understand where a patient was at any given point and why the right arm was doing what so that the right could understand what the left was doing and vice versa. Does that make sense? All right. So we'll start with nursing procedures. So we've worked through some of these structural pieces, and now we're going to get into what I think within our clinical model really addresses that patient engagement aspect of that study that we talked about at the beginning of the talk. So we have a absolutely fantastic behavioral health nursing lead who, again, is the heart and soul of the operation. And everything that we're going to talk about for the next few slides is directly a result of her initiative in problem solving that has led us to iteratively develop our model so that we can maintain high levels of engagement. So some best practices on the next two slides are what we've developed and learned experientially. So we don't want you to have to reinvent the wheel if this is something that you're doing at your shop, right? And so we're going to share our knowledge here. So the things that we've discovered work the best. So the first slide here, we'll talk about intakes. So direct referral processes, right? So this is really, really important. So how many of you have ever sent a referral for a specialist and it goes into the ether and it disappears forever? Yeah. That should be everybody because that's the way modern medicine works. It's the ether and then it's gone. How many of you have ever had your nurse or you call a clinic and get a patient an appointment with a specialist? Yeah, which works better? Yes, right. It is always better to talk to a human, believe it or not, than it is to send out a fax to the ether. So we have a direct referral process that really facilitates care. And our ethos, again, we need to strike while the iron is hot, and we need to prioritize same week or next week access. And so we have our different clinics have a direct referral line where they can call Melissa, who's our behavioral health nursing lead, to get the patient an appointment. So before that patient leaves the clinic that they're initially being seen at, they can have an appointment to come see us in the PCAM clinic within the next week, right? And so something really, really important. The day before the appointment, Melissa also operates as our care manager, so she'll chart review and see whatever health maintenance or intake assessments that the patient may need and prepares those. At the intake appointment, she has them complete paperwork and providing other screening instruments as needed. And we won't get into the details of sort of what screening instruments we use or what we recommend. I can talk to you about that if you're interested. And we've sort of learned and developed and adapted some things over time. And then importantly, as the patient is seen, so the patient comes in, they get seen, they leave the clinic with their next appointment already scheduled. So again, big thing is we're not just pushing patients out and saying, okay, well, we'll call you for follow-up, or just saying, okay, we'll come back in a month and, call for your appointment, that sort of thing. This is a really intentional and intensive engagement and scheduling practice that hopefully increases the chance of someone returning to care. So In between that intake appointment and follow-ups, right, Melissa, our behavioral health nurse, maintains a list or registry. And this is really, really important, right? And so there are like formal registries that you can develop within the EHR, and then there are informal registries. This is like writing it down on a piece of paper and locking it in the filing cabinet sort of thing. But either way, a registry or a list of patients is crucial at making sure that nobody gets lost to follow-up, especially because guess what? Melissa goes on vacation and like gets sick sometimes. And so if she's out for a while, we need to have an easily accessible list so that whoever comes in who's been cross-trained to do this can just pick up where she left off. And so really it's creating that system to do this successfully. So a little example here, how many of you have patients who miss their appointments? Yeah, exactly. Like it happens, right? It happens. So if we have a patient who missed their 3-month follow-up for more refills for Suboxone, let's say they have opioid use disorder, they're getting Suboxone every 3 months, doing great, and they missed their appointment. Or even before that, their appointment may not be scheduled yet because our schedules aren't out 3 months in advance, that sort of thing. Melissa has that registry, has that list of, okay, Jane is supposed to have her appointment in April of 2025, so I'm going to call her on this day to get the appointment scheduled. Make sense? The last thing is, and I think that this is something that seems so common sense, but just as a reminder for us as the DEA regulations have changed, and hopefully, knock on wood, will be more permanent in the near future. Telehealth is something that's going to be available for more people, right? And so we do a lot of phone visits, we do a lot of telehealth, and ultimately this is just leaning into that mentality of doing whatever works best for the patient. And so transportation, employment, all of these other things oftentimes will limit a patient's ability to come into the clinic, but most patients can receive a telephone call. And so if that's what works best for the patient, awesome. We're going to do that. Some patients say, I absolutely need to come in and see you every month, and we want to be able to do that too. So just establishing for that patient as part of that registry process, this works best for Jay, this works best for John, that sort of thing. And this is straight from Melissa, our behavioral health nurse lead, and that she has communicated in prior talks and that she wanted me to communicate to you today. Most important things beyond the procedures and processes that she has developed are accessibility, patience, and persistence, right? So when we talk about stigma, we think that stigma is less in that primary care context compared to a specialty context. And these are the things that we can do to really reverse or undo what that patient perceives as stigma, right? So we can make sure that things are as accessible as possible. We can make sure that we are as patient as possible with scheduling and rescheduling as much as we need to until the patient can come in. And persistence, this is where registries and list tracking and keeping on top of things really send that signal to the patient that we haven't forgotten about them as we're walking alongside them in their addiction journey. Questions about that? I'm going to take a drink of coffee. Anybody else have coffee? Now would be a time to get a swig. All right. How are we doing on time? 16 minutes for Q&A. Perfect. Great. I only have 75% of my information to go through still. Just kidding. All right. So the next thing we're going to talk about is clinician proficiency. So we've walked through the structural barriers or structural elements of the model. We've walked through procedures and practices that increase patient engagement. Now we're going to talk about clinician proficiency. So how many of you here have heard of the Waco Guide to Psychopharmacology? Awesome. Yeah. So this is a clinical resource that the behavioral health team at Waco Family Medicine has developed to support the evaluation and treatment of behavioral health disorders, substance use included, within primary care. And this is something that is freely available. You can go to www.wacoguide.org and get this resource, access it, use it. We don't make any money off of this. It is free, we promise. Something that we have worked on over the last several years to address this idea of being able to equip and empower primary care clinicians to treat behavioral health disorders. And we've worked on developing the substance use disorder section over the last 3 to 4 years in particular. So, the Waco Guide is free. I'm going to say that like 18 times because I don't think people believe it. You say it's free, people are like, it's too good to be true. What are you're mining my data and selling it to Amazon or whatever. No, not at all. We just really want it to be as useful and as available as possible. Each of the tools within that library, so the Waco Guide library has tools for specific disorders, right? In each of those disorders, the tools for those disorders has 3 pieces. It's got an algorithm, so this uses logic, so yes, no, if then logic, to complement your medical decision making. So for example, you have a patient comes in depressed. Do they have bipolar disorder? Yes. Okay, see bipolar disorder. Do they have a history of mania? Yes. Okay. And it adjusts sort of how you flow down the algorithm based on those key questions. It also has prescribing information. So if you get to the end of the algorithm and it suggests that you use sertraline or fluoxetine, right? It's got recommendations for how to start that medicine, how to dose it, how to titrate it, what are the common side effects, those sorts of things. And then it's got sort ratings. So who reads American Family Physician in the audience? Anybody? Yeah, so do you know those ABC ratings that American Family Physician has? So we have those for all of our adult and adolescent substance use tools, and we're adding them for our adolescent tools, right? Importantly, we just want to highlight this is where the evidence comes from, right? This isn't just my best guess at this. This is we've read articles and guidelines and synthesized them in a way that hopefully is going to be most usable for you, and those sort statements are what lend some credibility to that process. So I talk about that this didn't just come out of nowhere. This isn't just some sort of black box that you put in, shake the magic 8-ball and get sertraline. Yes, wonderful. This actually came from evidence. So we took literature and guidelines and synthesized a draft, and then we worked with our partners at MGH Visiting. So these are psychiatrists from Massachusetts General Hospital. To vet the tools and go through essentially what is an expert peer review process. So here's just an example of some of the folks that we worked with for addiction medicine in particular. And so Dr. Willens and Dr. Kehoe are a couple of the preeminent experts in addiction medicine, both working at MGH and Harvard Medical School. And the list goes on from there. But what we did with these folks, I think, is the most important thing. Right? So we took this initial draft of the tools. We start with the evidence, the literature, the guidelines, come up with this initial draft with the algorithms and the prescribing information. And then we take that and pass it through what we call primary care reviews. So I mentioned in the very beginning that a lot of literature and guidelines is written for the specialist in mind. Well, what we tried to do was decipher this and synthesize a clinical resource that was specifically for the primary care clinician, right? And so this is with faculty at Waco Family Medicine. We then take that to our independent reviewers, right, at MGH Visiting. So in this case, this would be the tool for stimulant use disorder, where we worked with Dr. Willens and Dr. Kehoe here to develop the stimulant use disorder tool. They reviewed this independently, and independently arrived at the decision that this represents the best approach to the treatment of this disorder within primary care. So pretty incredible, 2 experts agreeing on this, but as you can imagine, there are times whenever there may be some divergence of opinion or disagreement, in which case we enlist a third reviewer to help us establish a consensus. So we call this our modified Delphi process, and for those who do qualitative research or just research in general, may be familiar with that Delphi process as a methodology to help establish consensus around an area where there may not be consensus, and so it seems like it's pretty apt to be able to establish consensus on a decision support tool for behavioral health treatment, since there aren't primary care behavioral health treatment guidelines, right? And then finally, we sit down for a final review and publish this on our website. I mentioned the website, www.wacoguide.org. We also have an app, so an app on iOS and Android that, again, is free to download. We don't ask you to register. There's nothing behind a paywall. There's no data tracking, anything like that. We just want it to be as freely available as possible. So just an example of some of the different tools that are in here within this resource, right? We've got PTSD, depression, bipolar disorder. Essentially, if it walks through the door in primary care, right, we have a tool that will enable you and equip you to evaluate and treat this, right? So everything the line that we use is everything with 1% prevalence or higher, and even that, we have a few things that maybe have a little bit less than 1% prevalence that we include anyway. As far as substance use disorders, we think that it's probably the most comprehensive go-to resource for quick recommendations on substance use treatment, right? So we have alcohol use disorder recs, opioid use disorder, tobacco use, benzodiazepine and stimulant use disorders, and we also have these disorders with the exception of benzodiazepine deprescribing for adolescents as well. So talked earlier about adolescent treatment receipt being super bad compared to general treatment receipt for addiction medicine. We really wanted to lean into that and provide adolescent tools that could help folks. Just an example of what the algorithm looks like. So you see this is for medications for alcohol use disorder. You've got recommendation for 12-step at the top, recommendation for pharmacotherapy, and then some key questions are going to help you establish, well, what first choice pharmacotherapy should we be recommending? Is it acamprosate or is it naltrexone? And then the dosing recommendations for each of these here, and again, all of the medicines that are listed within that tool have the dosing and side effects listed in the dosing guide. We like to say it's not a comprehensive list, right? But it is a pretty good start as far as being able to quickly get some information and prescribe a medication for a patient. And then this is the SORT rating for alcohol use disorder in particular. So looking at that ABC rating, A being high quality, patient-centered evidence, C being expert opinion or consensus recommendations, and B being somewhere in between. And so we can see here, so use benzodiazepines for ambulatory withdrawal treatment. That has a strength of recommendation A. That is high evidentiary supported and has a history and long track record of medical literature to support its use in the treatment of alcohol withdrawal. Just showing you what this looks like on the app as well. So instead of having just the algorithm, you can actually click buttons and sort of it'll ask you questions as you go along. So what's the disorder? Is there a special population involved here? Do they have a prior medication trial? And then ultimately it'll get you to the same place as the algorithm that you would work through organically in a stepwise fashion just by looking at the algorithm. It just does this in a way that is a little bit more UI friendly and a little bit more fun, a little bit button clicky kind of fun. All right, questions about that? Okay, so I want to talk about behavioral interventions, right? And so we do have an integrated behavioral health service at Waco Family Medicine where we have licensed clinical social workers who evaluate and treat patients alongside the primary care clinician. And I want to, because there was a pretty good sampling of people here in the audience that had IBH services, but I want to give a little bit of a sampling as to how that behavioral health provider interacts with both the prescribing clinician and the patient. And so this is not specific for the addiction medicine context. This is a primer on this at large in the BHI world, but there's a few different ways that clinician and the patient and the behavioral health provider can interact, right? So we have what's called the hallway handoff, which is where I go see a patient as the prescribing clinician, identify a behavioral health need, I come out, I find the behavioral health provider, give checkout, they go in and see the patient. Easy enough. We have what's called a warm handoff, right, which is where I bring the behavioral health provider into the room with me and say, all right, this is the behavioral health provider, they're going to talk with you about XYZ that we talked through, and then I leave the room. You have what's called a reverse warm handoff, which is where the behavioral health provider may have an existing relationship with that patient and goes into the room ahead of time. And then we'll do the same thing with me that I just did as far as the warm handoff goes, just in reverse, right? So I come into the room, the behavioral health provider fills me in on everything, and then they leave the room. This is awesome. And you talk about just time saving, like you get the rundown on everything, and then you can dive right in just the most efficient and effective way possible. And then lastly, we have a co-visit. So there are some times where there may be some more complexity, where you may need a couple of set of eyes in the room wherever you're working through a history together. And this is where a co-visit can be helpful, where this is me and the behavioral health provider in the room together. As far as the behavioral interventions that we have, it really is a potpourri, right? And so this is another area where we can really differentiate ourselves in primary care from specialty care. So within primary care, within our system that we have already existing, our behavioral health providers can provide a lot of different behavioral supports, right? They can do motivational interviewing, they can do acceptance and commitment therapy, cognitive behavioral therapy, et cetera, et cetera. And so we don't rely on one particular modality in any particular instance. It really is going to be what's best for the patient. And oftentimes what happens and what we see is that patients have needs beyond just psychotherapies or behavioral interventions for the substance use, right? This is where we can connect patients with treatment for the thing that's driving the substance use. And this is where this is so key, right? So PTSD, a huge rate of unhealthy substance use and substance use disorder in folks who suffer with PTSD. And the behavioral health provider can come in and engage the patient and be able to provide interventions or connect them with psychotherapy for that PTSD, right? So as opposed to a specialty setting where someone like an LCDC who has a fantastic role and skill set to be able to provide services in the substance use context, they wouldn't be able to do this necessarily, being able to address some of these cross-cutting issues, and those behavioral health comorbidities are a really, really big one. So that's what we find most of the time, actually, is that the services that people most benefit from and the ones that they need are those outside of the pure substance use treatment realm. It's for the behavioral health comorbidities, and that's where our existing behavioral health integration model can be really helpful. But I want to just slam this home really, really strongly here, that behavioral interventions are not required for treatment. And so this is something in the specialty world that you'll see often, which is, well, if you want your naltrexone, you've got to go to group. Or if you want your Suboxone, you've got to meet with our counselor. Or if you want your methadone, you have to come in and meet with the counselor. And this is so, for some patients, it's very helpful. Don't get me wrong. But it is so antithetical to individualized treatment for that patient, and oftentimes contributes to low retention and poor engagement. And so our philosophy here is that if there is a need for a behavioral intervention and the patient wants this, it's something that we have and we can use to support their treatment, but it's not something that they have to do in order to receive medication therapy in particular, which is how oftentimes it's used as that sort of carrot in the specialty addiction world. I can talk more about that later. I feel very strongly about that, but I'm going to move on to our last point here. So the last thing I'll mention before we take a few questions is the attitudinal belief piece, and the way that we've addressed this in our context is through a graduate medical education curriculum. This is also something that we can talk about even further upstream with undergraduate medical education, but for our context, we've developed a residency curriculum with goals and objectives and resources that I'm happy to share with you, that goes through a sort of a 2-week training period to really upskill primary care residents, whether that's pediatric, family medicine, whatever, in addiction medicine. And I'm happy to share that curricular resource with you at some point if you'd be interested in that. But that brings me essentially to the end here. So final takeaways, I really strongly feel primary care is an optimal way to treat addiction. Our model, we hope, addresses some of those most essential elements that have been identified as some of the key points that hold primary care back. But ultimately, this comes down to that nursing initiative, clinician proficiency, those ad hoc behavioral interventions, and educating the clinicians of the future to make sure that we can set the primary care system up at large to address the ongoing addiction and overdose epidemic. So, that being said, happy to take some questions. So the question is, there are some patients who are receiving services in an addiction medicine specialty clinic or just addiction medicine consultation clinic, and have sort of detached from their primary care medical home. The exact same model that we have in terms of, I'm a primary care clinician and addiction medicine clinician doing this within the context of the patient's medical home, but the question is, how do you make sure that they get the primary care that they need for the other chronic diseases outside of the addiction treatment that they're receiving? I'm with you. I think that we do have some of that within our clinical system as well. The best way that I think that we've come up with addressing this is through the sort of common pathways, right? And using sort of step up, step down models. So it's like, okay, in this case, you're going to get referred over to me, we're going to do this, and then these are the criteria for de-escalation or referral back to your primary care clinician. And the roadmap that we have between the two of us in order to be able to understand where you are in that continuum of care is something akin to like a Waco guide pathway or decision tree specific for your clinical system. That's the best way that I can think of as far as how you do this. But I'll tell you, we've had some similar kind of issues as well. We have certain people who have gone sort of gung-ho on this, and we have some that haven't, and that we're still doing their refills for. Luckily, we haven't had the same issue as far as not having them do like their chronic disease management. Like we're not doing that. We've sort of set that expectation early that they need to be able to see both. And maybe that's the other half of this, which is setting the expectation early with patients. So I mentioned earlier that we had some research that we were doing. We have done some interviews and some qualitative data analysis looking at this idea of retention. And we know that within our model, we have a signal and a theme that has emerged of increased facilitation and entry into care. And we're piggybacking this with a qualitative study that's going to look at this idea of what are our retention rates actually compared to specialty care contexts. But I don't have an answer as to if they receive all of their care under one roof, that the retention rates would be higher. I think what sort of proxy data we have, though, about patients who do get efficient treatment within primary care, especially for multi-morbidity, is high. And so I would imagine the answer would be yes, but I don't know for sure. The question was, do you have any experience with managed care organizations or MCOs mandating behavioral health treatment for, is it a prerequisite to get medications or just as part of addiction treatment? Because I think that we have and again, I'm going to harp on this for just a minute, but we have mountains of evidence that show us that that is not the best practice, right? Especially for opioid use disorder, right? Opioid use disorder really is the exemplar and sort of the shining example of behavioral health interventions should not be a requirement to receive medication treatment, which speaks to, one, the individualized nature of care that patients deserve, but also, two, the effectiveness of medications in and of themselves to prevent overdose deaths and achieve access and success in treatment. So we have some other things in Texas that are a bit wonky as far as prior authorizations for medications and dosing limitations that we're trying to work through. But yeah, unfortunately, we don't have that experience. Or fortunately for us, we don't have that experience, but hopefully that's something that can change in Tennessee. Sorry? For Suboxone. Yeah, which is potentially deadly, and we've told our senator as much. Great question. So the question is, how do you kind of flag, I'm just going to generalize this question, is how do you decide who or how to interact with the behavioral health provider whenever you're seeing patients in clinic using those sort of 4 structured models that we have? The answer is that most of the time this is ad hoc, right? And this is sort of as clinic flows and sort of what our needs are, things may change. But there is a strong argument to be made for when you huddle at the beginning of clinic, which we should all be huddling, identifying a patient on your list for that day that may benefit from a co-visit. And so to that point, yes, I think that that's a pre-clinic identification of that patient potentially. Yeah, great question. All right, I'm happy to take more questions. I know our time's at an end, but thanks for being here today.